The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. My name is Ann Potempa. Welcome to today's presentation, which is part of a series of webinars presented by the Division of Public Health, Section of Chronic Disease Prevention and Health Promotion. This webinar series was created to provide a way for us to talk about our projects and explore how we can work together. There are a few housekeeping items to go over before we start. If you are listening by phone, please keep it on mute. Please do not put this call on hold. If you receive a call, please hang up and call back in later. The webinar is planned for 30 minutes, which includes a 20-minute presentation followed by 10 minutes of questions and answers. A recording of today's webinar will be sent to all participants, and the slides will be made available online soon. Next slide, please. Audio for this webinar will come through your computer or telephone. If you have any technical difficulties, please let us know by sending us a message through the question box or the chat box. All other questions can be held until the end of the presentation. And at that point, if you need to ask a question, you can type it in the question box or the chat box, or you can raise your hand by clicking on the hand button, and then we can unmute you and let you know you can ask your question that way. I'd like to introduce our speakers today. Please welcome Jessica Quinn, the public health specialist who runs Alaska's cancer prevention program. And we'll also hear from Mac Wood, a public health informaticist with the Maternal Child Health Epidemiology program in Alaska. First, we'll hear from Jessica. Thanks so much.
Thanks, Ann. So today we're gonna just give you a brief overview of our agenda. First, we're going to talk a little bit about the history of the Alaska Health Equity Index. Then we'll show you how to access the tool, how to navigate the tool, which will be kind of an interactive demonstration, how to access data from prior years, and then talk through a couple of examples of practical applications. Then at the end, we'd love to engage in some question and answer and talk about ways that you see that you could use these tools in your programs. So the Alaska Health Equity Index is based on the Social Vulnerability Index developed by the CDC's Geospatial Research and Services Program, which was first established in 2011 to help inform disaster management and emergency preparedness efforts. Next slide. The CDC defines social vulnerability as a community's ability to prevent human suffering and financial loss in a disaster. The CDC's Social Vulnerability Index uses U.S. Census data to determine the social vulnerability of every census tract. They rank each tract on 15 social factors, including poverty, lack of vehicle access, and crowded housing, and groups them into 4 related themes. Maps of the 4 themes are shown in this figure here. We'll go into more detail of what these factors mean later on. Each tract receives a separate ranking for each of the 4 themes, as well as an overall ranking to allow for comparison across larger regions. Next slide. The CDC offers access to interactive maps and prepared county maps that utilize the Social Vulnerability Index, or SVI, through their website listed here. In these examples here, the darker areas are considered more vulnerable or have less ability to prevent human suffering and financial loss in a disaster. A few disadvantages to the CDC's tool is that most recent nationwide data is from 2016, and they only update the maps every 2 years. Another challenge is that their scale is set to compare all counties in the United States to each other, which doesn't allow for more nuanced visual comparisons within Alaska. Next slide. So it only took a few years for the public health world to realize that this tool could be used to examine relationships between these social factors and outcomes such as physical activity and teen pregnancy. Next slide. In fact, over the past year, several new online tools have incorporated the Social Vulnerability Index to examine COVID-19 pandemic vulnerability, track outbreaks, and inform vaccine allocation planning. Next slide. So now I'm going to pass it off to Max, who can talk a little bit about how to access the tool.
Great, thank you. So there's a couple ways to access the tool currently. If you go to healthyalaskans.org, we have a link shared there right now, but in the near future, it's going to be embedded directly on their website. And so you'll be able to go to healthyalaskans.org and then follow that health equity to the health equity index, and it'll be an embedded interactive link. In the meantime, the two links below that long URL and the short URL, they lead to the same spot. They get you right to the GIS interactive map, and those links are going to stay consistent going forward. So in the past, they changed every year when the data was updated. Now we've got a system where that link will stay the same, and it'll get updated with the most current data, and then a new link will get created with the archived version. So that'll be easier to keep track of. And so then next, I'm going to kind of just walk through the tool and demonstrate some of what's going on in it. So let me pull over. And so like Jess had said, the Alaska Health Equity Index is based pretty much exactly on the Social Vulnerability Index. We do add one additional variable to the socioeconomic domain, and that's insurance coverage. Other than that, it's the same process as the SVI. And so there are 4 domains consisting of 16 variables that get pulled from the Census American Community Survey 5-year estimate data. And they include, in the socioeconomic status domain, poverty, unemployment, per capita income, high school education, and insurance coverage. And in the household composition and disability domain, that proportion of older population, 65 plus, those under 18, disabled population, and single parent households. And then minority status and language domain includes just 2 variables of minority and speaking English less than well. And then that final domain of housing and transportation includes multi-unit structures such as apartment complexes, mobile homes, overcrowded homes, no access to a vehicle, and group quarters, which includes things like dorms, treatment centers, nursing homes, barracks, and correctional facilities. And so the Alaska Health Equity Index examines these variables at the census tract level. There's 169 census tracts in Alaska, but only 165 of them are included in this analysis. So there's a few excluded: Hyder, Cape Port Alexander, Prudhoe Bay, and Hobart Bay, just due to data limitations. And so now I'll just kind of explain the ranking a little bit. Percentile ranking is used to compare these census tracts to each other across the state. And so percentile rank is calculated for each of the 4 domains along with an overall measure of that vulnerability. And those values range from 0 to 100, with the higher values indicating higher vulnerability. So a tract with a rank of 10 in a given domain is better off than 90% of other tracts and worse off than 10% of the tracts. And so now I'll just walk through a couple of these maps. This first section is just looking at some different geographic regions of Alaska. And so census tracts are the ones that most of this analysis is going to be looking at. And all of these maps you can click on, and there'll be a pop-up. For these region ones, it's just a label. We'll see further that more information is included once we get into the domains. But all of these maps, you can type in an address and click enter, and it'll zoom into that area. If you're on a smaller screen, you can expand it to utilize all the screen space. Over here in the bottom left is the legend. And then if you're on a device with location enabled, you can click on that little location button and it'll zoom into where you're at. And then these are just the zoom in and out functions. So if you were to zoom in somewhere and you wanted to get back to the statewide picture, the default map view is the little home button and it'll bring you back to the statewide. And so I'll just walk through this overall rank first. And so when you click on a pop-up, you'll see the domain rank for each of those domains 1 through 4, and then the overall rank, which is the combination of domains 1 through 4. And so again, those higher numbers are higher vulnerability. And so this Iditarod census tract has a vulnerability rank of 95. And then each of these sections of maps, if they have just one or a couple that are tied for the most vulnerable or the least vulnerable, they've got buttons that you can click on and it'll zoom in. So the most vulnerable census tract in the state is the Merrifield and vicinity. And so you see they've got a overall rank of 99. And then the same goes for the least vulnerable, and the least vulnerable in the state of Alaska is that lower Eagle River tract with an overall rank of 0. And then if you just click it again, it'll zoom back out to the statewide map. And then there's a bunch of these buttons for public health regions, and they'll zoom into the different public health regions just to be able to kind of see if you're interested in a specific region. And then you can always just click statewide and get back to it. And so then I'll just go through one of the domain-specific rank maps, because all the other ones that follow have the same content. It's just a different domain. All of the layout on the left is the same. The only difference is when you click on one of these pop-ups, rather than just seeing the breakout of those ranks, you get these two characteristics of that census tract throughout this map series. You get household number and population size. But then specifically on this socioeconomic status section, you get that socioeconomic status rank. And then you also get the variables, poverty, unemployment, per capita income, high school diploma, and uninsured that this domain consists of. So you're able to kind of see what's making it that 95 percentile rank. And so then I'll just kind of breeze through the next few maps because they're the same setup, just different domains. And since we've got some limited time, and so I'll jump into the flagging and explain that a little bit. So flags are generated for variables that are in the top 90th percentile. Flags are used to identify tracts that may or may not appear relatively invulnerable at the domain or overall rank level, but have high vulnerability in select variables. And so domain flags are the sum of variables in that domain that are flagged, and the overall flags are the sum of that set of 16 variables that are flagged for being in that top 10 most vulnerable. So a tract with 5 variables with percentile rank over 90 would have 5 out of 16 flags, and of those 5 flags, they could be distributed in a number of different ways across those 4 domains. Or they could be all in that first domain. And so you'll see when I walk through this, the overall flags map is similar how it shows that breakout of the overall flag. Overall, this is not the right map. This should be showing all of the domains added together. I think if I refreshed my window, the pop-up would be correct. Right now, it's showing the pop-ups for one of the specific domains, the minority status and language. It should be showing all, it would say total flags, and it would be out of 16, and then it would have domain 1 through 4, and it would show the numbers of flags in each of those. But then once you get into, I'll just refresh my window. There. Now it's looking right. So the overall flags, it's going to show 7 total flags, and then it's also still going to include that household size and population size, but then it's going to show that breakout of, so there's 7 total flags in that YK census tract, 4 of which are coming from that socioeconomic status domain, 1 from minority status and language, and then 2 from housing and transportation. And so then when you get down into the socioeconomic status specific, then it shows you 4 in that socioeconomic status domain and which ones of the variables in socioeconomic status that are flagged. And so then these just continue the same process for the different domains. And then when you get down towards the end, there's a couple links that you can click on. Data sources just sends you to data.census.gov, which is where the data is being pulled from. and then the methodology page on the CDC's website, kind of describing the percentile rank and everything in more depth. And then one of the newer pieces of this is this archive version hub site. And so if you click on that, you'll actually be able to click on the other archived versions. And so on this hub site, every time census data is updated, we'll just add in a new a link to the previous archive, and then that current URL that we were at will have the most recent data. And then we're also going to be adding in any other GIS products that are related to the Health Equity Index. So like right now we've got one, a story map of some ladies first data that utilizes some of this Health Equity Index data. And then another cool thing that's pretty recent to the story map is this ability to download raw data. So those maps are nice for visualizing, but not really for analysis. So if you're a data user that's wanting to download some of this data to do any type of statistical analyses for your programs, you can come in here and you can either download theme-specific data, or you can just get the overall data. And so you can explore the data here within this. You can download the data via a spreadsheet, or you can even link to it as an API. And then that pretty much wraps up the demonstration. And I also, in that demonstration, showed access to the prior year's data. But here's a specific link to that hub site if you didn't want to access it via the story map. But it's probably easiest to just keep track of the one link, and then it's pretty much got everything included in it that you'll need. And so now I'll toss it back over to Jess.
Thanks.
To what?
Great. So I spoke at the beginning about ways that researchers and epidemiologists can look at the relationship between these indices and public health outcomes, but there are also many practical applications in our public health work. So a local example here in the state of Alaska is within the Ladies First Breast and Cervical Early Detection Program. So they pulled statewide zip codes with low index scores to target radio and digital messages, encouraging women to enroll in their services through a contract with iHeartRadio. They're also exploring using the index to pinpoint Anchorage neighborhoods for one-on-one navigation and enrollment through their outreach contract with the YWCA. Next slide. More broadly, funding agencies and programs can require applicants to use the Alaska Health Equity Index to identify service areas in RFPs, contracts, and grants to assure equitable allocation of services and resources. Programs and organizations can use the index to describe communities and explain differences in health outcomes in reports, action plans, and funding applications. And they can also use the index to identify practical approaches to improving health outcomes in specific communities. I know one example in the Utah Department of Health, they prepare reports for each legislator on their own district, showing disparities in chronic diseases and mental health by census area. And they include a score or rank from their version of the Health Equity Index to provide a more concrete approach to health equity for policymakers. And in fact, they even had a senator propose a bill for community improvement program using their Health Equity Index as a funding criteria. So next slide, we're going to kick it back out to our listeners and see if you have any ideas, or if you've been thinking about cool ways that you could apply this tool to your work, or if you just have general questions on accessing or using the tool. We have a couple minutes for that now.
Thank you, Jess and Mac. Arthur, are we seeing any questions in the question box? Can you read them out loud for our speakers?
Yes, the first one I see is, how accurate do you feel the underlying data is for Alaska by census area?
How accurate do you think the census level data is? Oh.
Mm-hmm.
So this analysis doesn't look at the margins. The tract level, the smaller the region, there is going to be pretty wide intervals, but it's kind of that next step from census area boroughs, which if we did the analysis at that level, it really wouldn't be as helpful in identifying geographies. But you could always pull that data and look at the margins that census reports to make sure that some of the data in those smaller regions is accurate. But it's not something that we've done or that CDC does with their SVI.
Sweet. And then we have another one from Julius. She says, hello, my name is Julius, and I am a statewide bike head coordinator for Alaska DOT MPF. Are you aware of any projects that have looked at the comparison between the SVI access to active transportation facilities, transit, etc.? If not, I think I might be an interesting project and something we might be able to collaborate on. Sorry, that was a long one.
Yeah, I'm not familiar with Mac. I don't know if you are, Mac, but it sounds like a really cool idea.
Yeah, I'm not. I know that a lot of the analysis that gets done with the social vulnerability index data is spatial autocorrelation data. That's what a lot of the studies that Jess linked to that have been done with public health data, that's typically the analysis that they utilize.
Nice. The next one is from Emily. It says, does insurance coverage include access to tribal health, or is it limited to commercial insurance, Medicaid, and Medicare?
Unfortunately, it doesn't include IHS because the census considers IHS as a payer and not an insurer. And so that is a limitation of that added in insurance coverage variable.
And then the last one so far is, can you segment by a defined population? I think it might be referring to those maps.
So not within the map you can't. You technically could with the data. The way that I do the analysis, I use an API straight into the census data, and so I pull all of the data. You could use that same methodology based on a restricted data set. So if you just wanted to look at a sample of the population, you would pull that set of data and then just run those percentile ranks with that.
Nice. And then a new question just came in from Julie. It is, are there plans to use these maps to identify areas to target for vaccinations, specifically for COVID-19?
So the COVID vaccination team is working with CDC on utilizing some of the social vulnerability index data, which is what this is based off of. So yeah, they are planning on using it, at least I don't know how much it'll be utilized. I just know that there have been discussions about utilizing it in those lower vaccination areas, trying to identify the kind of outreach pockets on, since like Anchorage, you see the vaccine utilization in Anchorage as the municipality. But if you look at that map of the number of census tracts, there's, I don't know, around 50 of them probably. And so being able to identify what parts of Anchorage is where this index is super helpful.
And then that is all the questions I have so far.
Great, thank you, Jessica and Mac. Just a reminder to everybody, these slides are being recorded in the video format. We'll be posting the PowerPoint and the video slides on our section's webinar page in the coming weeks. And when we do that, we will send a reminder email to all the registrants so that they can go and view those again later. Thank you for all the questions that came in today. If we're not—
I did have one more.
Oh, we do have one more. What is that?
Yep, I missed this one. It is, hi, this is John Harley at UAS. I'm curious regarding the application of the HEI to other census geometry scales. My question is, are there limitations for drilling down on smaller scales driven by the margin errors surrounding the census data? Or are there concerns over privacy issues given the very small population of some of these census areas?
So I don't think there are any privacy concerns with the census data. All of that data is already disseminated by the U.S. Census Bureau, and they do all of their fuzzy number, whatever. I think this newest census, they're implementing something new. I don't know all the details about it. But I've seen some of the work that you've done down to the CDP level, and that's super beneficial as well. It's just kind of digging down at that one further step. But like we had the question earlier on kind of the accuracy and at the margins of that data, I think the smaller population areas you're going to get into, that issue is going to increase in magnitude big time. And I think we would just have to be careful on some of those really small population areas, the accuracy of some of that census data. Because I assume in some of those areas, it's a handful of respondents ending up representing the entire region.
And then we have another question from Sydney. Since you mentioned that Indian Health Service health coverage is not included, I'm assuming that Veterans Affairs healthcare coverage is also not included. Is that correct?
That one I'm not positive on. It would be whatever the Census Bureau classifies that as, and I don't have that answer off the top of my head. Sorry.
And then let's see if there's any more. I do not see any more questions at this time.
Thanks for all the questions. This has been good feedback.
Yeah, and Mac and Jessica, do you have anything else, or are you ready to wrap up?
No, I just hope this gets wheels turning and people thinking about ways that we can use this tool in our work. So thanks for everyone's attention today.
Thank you very much, and this will be posted online soon. Thank you for your time.